So we're getting very close to the end of pregnancy. We're in your last month, and there's one more test that we need to talk about, and that is for Group B Strep. So in the mainstream world, this is just standard procedure that you get to the last month of your pregnancy, and then you have this test. It's a simple swab for a bacteria that is pretty common. Somewhere around 20 to 30% of people have this just in their intestinal or genital tract. And it can be just a normal part of your flora, but it can also present a problem. So it can cause newborn sepsis. It can cause later sepsis as the days go on. But it's not a guarantee. If you have it, it doesn't mean that your baby is going to get it. So if we look at 1,000 women, somewhere around 250 of them will be colonized. And of those 250, somewhere around 125 can pass it on to their babies. Of that 125, about 2 might develop newborn sepsis. So somewhere around 2 in 1,000, 1 or 2 in 1,000 is the rate of GBS infection. We don't know why some women who have it don't pass it on, and we don't know why some babies who are definitely exposed don't get it. We know there's some risk factors. Among the risk factors are preterm birth and prolonged rupture of membranes, and that's a chicken or egg scenario because sometimes an infection causes the membranes to rupture, and the presence of an infection during labor or prior to birth is a risk factor for newborn sepsis. Again, why did the membranes rupture? Were they susceptible because they were weakened by an imbalance of bacterial flora? And why are some babies more susceptible than others? So those preterm babies, those low birth weight babies, if you've had membranes ruptured for a very long time and you've had many, many vaginal exams, we try to limit those to the bare minimum number. In fact, it is possible to get through labor without a single one. All of those things are risk factors for increasing the risk of infection. So we can look at whether you are at risk, and we can test for it, and we can do things to mitigate the risk, like trying to keep your membranes intact as long as possible. We're not going to rupture them if they don't rupture by themselves. But we're also going to look at why it happens to begin with. Have you had a urinary tract infection at any point in pregnancy? Can we test and see if you have Group B Strep in your urine? And if we know that already, then maybe we don't need to do this swab at the end of pregnancy because we already have that information. We can already do with that what we will. And just like any test, we need to know the accuracy of this test. And the accuracy of the swab is less than the accuracy of a urine culture, because you can test positive one day and a few weeks later, when you actually go into labor, you might not be positive. It can be a transient condition. A lot of people talk about using probiotics or using fermented foods to try and rebalance your flora, and in general, there are no downsides to good nutrition, really. The only potential downside I could see to that is if you're counting on that to fix everything. Don't do that in place of needed medical attention, but other than that, there are no downsides to good nutrition, and ultimately that is what's going to help restore a good balance. But if you have this and we know that you are positive for it, what can we do? Well, the standard protocol is that you get IV antibiotics during labor. If you're at home, that's a little harder to do. So you would have to evaluate, do you want that IV antibiotics? Do you think you might be that 1 to 2% of people who are colonized who would pass it on, and the baby might have a problem? There are other protocols that people use to varying degrees of success. Some people use a Hibiclens douche in the weeks leading up to birth to try and rebalance their bacterial flora. There's mixed results with that, but there are all kinds of things that we can do to try and stack the deck. But really, at the end, we're going to be watching your baby anyway. The first 24 to 48 hours of your baby's life, we're going to be watching your baby very closely anyway. We're going to be watching for any signs of difficulty in breastfeeding, any signs of difficulty with breathing. no matter what your risk factors are, we want to know how your baby is transitioning. So it is a possibility to say, I know I'm positive, I'm going to do everything I can to eat well and try and restore that flora, and we're going to keep the membranes intact if we can, we're going to keep everything out of the vagina, and we're going to make sure that we stack the deck in this baby's favor. And regardless, we're going to watch this baby. And if you also are free to skip the test. You don't have to do this test. The downside to that is, in the event that we transfer, it's possible that your baby will be treated as if they were definitely exposed and are definitely going to have that problem. Those are things to keep in mind. In the event of a transfer, it might be nice to have that test on record. It would be really nice to have a negative test on record, especially, but if you have a positive test on record, we can have the records of everything that we've done to try and mitigate the risk. But ultimately, this is a difficult decision to make, and I will help you with all of the information that you think that you might need, and we will do our best. But in the end, we're going to look at every baby, and we're going to make sure that every baby is transitioning well, regardless of what their risk factors were. So I hope this was helpful, and I hope that in the last month of pregnancy, we can just enjoy a lot of this, because this is such a sweet time of transition. Let's not lose sight of that, too.